Welcome to this training session for neurosurgeons. This session, as you all know, is regarding emergency neurosurgical procedures. In this session, we'll be discussing regarding optimal and quick management of subdural hematoma. So you all know, but let me tell it in a brief way. Subdural hematoma is accumulation of blood between the cortical surface of the brain and the dura mater. This is usually because of traumatic brain injuries, but sometimes it can be spontaneous. So let me share my presentation. Before sharing my presentation, let us discuss regarding the classical indication for surgery for subdural hematoma. An acute subdural hematoma requires surgery when it is the thickness of the subdural hematoma is more than 1 centimeter, the midline shift because of subdural hematoma and the underlying cortical edema is more than 0.5 mm. And also in some cases, which doesn't fulfill this criteria, but there is fall in Glasgow Coma scale, or there is a deterioration of the neurological status of the patient by more than 2 points, or when there is decortication, where is asymmetric posturing of the patient, or when there is asymmetry of the pupils without local eye injury, or when you have already placed an ICP monitor and it is refractory and it is more than 20 mm, more than 20 mm of mercury, even after adequate medical management. Now let us go into the surgical management subdural hematoma. As I keep on telling, for any emergency neurosurgical procedure, as a neurosurgical resident or a neurosurgical trainee or a neurosurgical consultant, you should be adequately trained. You need to be fast enough, at the same time meticulous enough. All these are life-saving measures, and so try to be as adept as possible at these procedures. So let me share my screen. So let us revise the classical indications for the surgical intervention for subdural hematoma. So a thickness of greater than 10 mm, a midline shift of greater than 0.5, greater than 5 mm, and in some condition where the thickness is less than 10 mm and the midline shift is less than 5 mm, but which is accompanied by neurological worsening by more than 2 points on the Glasgow Coma scale, asymmetric pupil, are fixed and dilated pupils, are where the intracranial pressure is more than 20 millimeters of mercury. So this is one classical example of an acute subdural hematoma. You can see the thickness of the bleed is obviously more than 1 centimeter. The midline shift, which I'm showing now, think this is a straight line which is drawn with the hand. So this midline shift is more than 5 mm. So this is a classical indication for surgical intervention in the case of acute subdural hematoma. So let us begin from the positioning. As I've told, I keep on telling, positioning in neurosurgery is very, very important. So let us see what are the important tips for positioning in for a case of acute subdural hematoma. First thing is, when you are positioning the head, would you prefer to put it on a head ring or a 3-pin headrest? This varies from surgeon to surgeon. I prefer to position the head on a head ring because it saves time. Because it's an emergency, every movement counts. So I prefer to put it on a head roll so that I will be able to save the time. I put a rolled sponge, a rolled towel under the ipsilateral shoulder so that I will be able to rotate the head to the opposite side at least by 30 to 40, at least by 45 to 50 degrees. This prevents twist on the neck. Suppose, because it's an emergency, suppose I have not cleared the neck of fractures because of any reason, then I would like to position the patient in semilateral position and secure the neck with a cervical collar. You can see the cervical collar if I have not cleared the neck of a cervical spine injury. If I have cleared the neck of cervical spine injury, I would prefer to keep the patient supine with the head rotated to the opposite side. One more important is you should ensure that the head end of the patient head is above the heart level. That is, I will place the patient in a reverse Trendelenburg belt position. This ensures venous return and prevents excessive bleeding. And also prevents an excessive bleeding. Coming to the skin incision, for a large frontotemporoparatal acute subdural hematoma, the classical skin flap which is usually taken is a falconer incision or the reverse question shaped flap. The flap starts in front of the tragus above the zygomatic arch. So this is the starting point. Then it takes the shape of a reverse question mark. It takes the shape of a question mark. That is, it raises superiorly towards the vertex. Just above the level of the pinna, I take my incision back and superiorly. I ensure that the parietal eminence is covered by the incision and about 1 to 1.5 centimeters from the midline. I turn it anteriorly, reaching the hairline. I will ensure that this distance from the midline is at least 1 to 1.5 centimeters. Some surgeons prefer to take the incision until the midline, but they ensure that there is sufficient gap between the burrows and the midline. And the midline. And the midline. One more thing, when you are taking this incision in slim patients, in majority of the patients, you can palpate the superficial temporal artery. So this is the superficial temporal artery which you are able to see. So when you are planning the incision, plan the incision in such a way that you are not injuring the superficial temporal artery. Superficial temporal artery provides blood supply to our skin flap. So if you preserve the superficial temporal artery, there are high chances that you are ensuring the viability of the flap. One more important thing which you have to take is put your entire efforts to make the base of the flap as wide as possible. If you make a flap like this, that is, base is very thin, but the length of the flap is very large, then this may compromise the vascularity of flap and this can cause skin necrosis. So try to keep the base of the flap as wide as possible. Coming to the next one, now it comes to the level of subcutaneous dissection. That is elevation of the subcutaneous dissection of the flap, elevation of the flap, reflecting the flap, and then elevating the temporalis muscle. The temporalis muscle is cut with a monopolar cautery along its posterior edge. Some people prefer to use a knife, but I prefer to use a monopolar cautery because it's an emergency. It's rapid. It will cause less bleeding compared to a knife. Then I use a periostral elevator and separate the temporalis muscle from the underlying bone. This is the direction of my periostral elevator, or a penfield number 3, and I separate the temporalis muscle from the underlying bone. When I reach this line, which is the attachment of the temporalis muscle, I encounter resistance. Either I detach the muscle with the same periostral elevator, or I can even use a monopolar cautery to cut over here. Some surgeons prefer to, and also some surgeons prefer to leave a small cuff of muscle attached to this bone flap. If at the end of surgery, I replace the bone flap, this helps me in suturing back the temporalis muscle to the bone. Once I have reflected the temporalis muscle, I achieve proper hemostasis. I forgot to tell you, once I elevate the skin flap, I apply scalp clips to ensure hemostasis. Hemostasis is very important at each and every step. Hemostasis needs to be meticulous, at the same time rapid. So the temporalis muscle is reflected anteriorly. The anterior reflection of the muscle is held either with fish hooks or in our institute to take a suture, 1-0 silk suture, and tie it with the help of glove bands or rubber bands. When I'm elevating the temporalis muscle, I ensure that the posterior root of zygoma, you can see the root of zygoma over here. The posterior root of zygoma is exposed at the posterior edge of the temporalis muscle, and the key burrow is exposed at the anterior one. One more precaution which I will take is when I'm reflecting the flap to prevent an acute bend at the reflection, I use a cotton roll or a sponge roll. This prevents narrowing narrowing of the superficial temporal artery or the vascularity. Once I am done, coming to the placement of the burrow. So one burrow is placed at the key burrow. This gives me access to the middle cranial fossa and also the anterior cranial fossa. The second burrow is placed as low as possible on the squamous temporal bone. So this is the squamous temporal bone. I place it as low as possible, as closer to the middle cranial fossa base, as closer to the skull base as possible. Third burrow, which is usually placed, is above the mastoid, but not very low enough because I don't want to open the mastoid air cells, which risks a CSF leak. If at all inadvertently I open up the mastoid air cells, I immediately thoroughly wax it so that there will not be post-operative CSF leak. Then the remaining burrows are tailored. They are placed along the frontal parietal bones along the midline, but ensure that at least they are away from the midline by 1 to 1.5 centimeters. If they are very close to the midline, you risk injury to the superior sagittal sinus. And this particular burrow, ensure that that doesn't come onto the forehead, which will be cosmetic, very bad to look at. And if it is very low on the forehead, you also risk opening up the frontal sinus. If the frontal sinus gets opened up, you will have to exteriorize the frontal sinus so that there will not be any future CSF leak. Once it is done, I connect the holes with a craniotome, which has a dural protector, and I open it up. If there's a fracture line running across the bone, particularly if it is crossing the midline, be careful there. You should be gentle enough, because if you are rough enough there, if you're not gentle enough, you can risk injury to the superior sagittal sinus at this point. Once all the cuts are made along the temporal ridge, I drill this portion with a drill. I make it papery thin along the zygomatic ridge. Then gently I separate this bone flap from the underlying dura mater. I use a periosteal elevator or a Penfield dissector. They are usually, dura is more adherent along the coronal suture. In elderly people, it may be adherent all along the bone flap. So you gently separate it from the bone flap, avoiding any tear of the dura mater. Once I have done it, I gently elevate the bone flap. Because I have already made the temporal portion papery thin along the zygomatic ridge, it should easily fracture off. If it doesn't easily fracture off, make it more papery thin. If you fracture off with a lot of force, there is always a danger that the fracture line, is it recording? Yeah, it's recording. There is always a risk that the fracture line can extend along the skull base into the foramen ovale or the foramen spinosum, causing injury to middle meningeal artery and torrential bleeding. So we have completing elevating the bone flap. At this point, the bone flap is clean, soaked in antibiotic solution. Then comes to opening of the dura mater. If there is a small, usually because it's a case of trauma, you can find small epidural hematoma in this region. If that is there, suck off the epidural hematoma. Try to identify the source of bleed. If it is coming from the bone, from a fracture line, wax off that fracture line. If it is coming, if it looks like a venous ooze, use fibrin soap, thrombinogen soap fibrin, or an gel or cotton patties to put pressure and stop the epidural bleeding. But most common source of bleeding is a torn middle meningeal artery. Identify the bleeding point, use a bipolar coagulation, and secure the bleeding point. So if there is epidural hematoma, apart from evacuation of epidural hematoma, you need to ensure that you are securing bleeding point. Bleeding point or bleeding source. Once epidural hematoma is evacuated, if there is a lot of cerebral edema, you also do a temporal craniectomy the way we do for decompressive craniectomy. You can watch my earlier video regarding decompressive craniectomy, how we perform this temporal craniectomy. But this temporal craniectomy, in my experience, is required in majority of the cases because acute subdural hematomas are associated with widespread edema. Then I open the dura mater. While opening the dura mater, I ensure that I open it inch by inch. I don't open it suddenly because sudden opening may cause rapid protrusion of the brain and injury to the brain. Second, so I open it inch by inch. Second one, when I'm opening it, I ensure that before I take a cut, the undersurface of the dura mater is under my vision. This ensures that I will not injuring any cortex underneath, and I am also not injuring any veins underneath. So I open in the dura mater, tuck it anteriorly, then the subdural hematoma comes into vision. Once the subdural hematoma comes into vision, I use gentle aspiration to evacuate it. I use a combination of microsurgical techniques along with adequate irrigation. So use adequate irrigation so that the blood clot gets separated from the cerebral cortex. Use microsurgical techniques so that you separate the hematoma from the cortex, from the surface of the brain. You can use tumor holding to gently pick up the clots. Once you start evacuating the clot, you will be able to identify the source of bleeding. The source of bleeding is usually a small artery or a vein on the surface of the brain. So you identify this one. If the source of bleeding is a very small one, you try to achieve hemostasis using a combination of Apchel or a Surgicel. Surgicel is fibrin, thrombins of fibrin. You use cotton patties to apply pressure. And if it is a significant bleeding point, you can use gentle bipolar cautery to achieve hemostasis. But achieving hemostasis is of utmost importance. At the same time, while achieving hemostasis, while evacuating the clot, be gentle enough so that you are not injuring the underlying brain. So once I have done it, this is the time when I take a decision. Whether I'm going to close the dura primarily or I'm closing the dura with an expansile duroplasty. If the underlying brain is below the level of the skull, is below the level of inner table of the skull, then the brain is not having significant edema. But also correlate this finding with your CT brain, because if there is severe injury, even though there is no edema right now, the edema can develop in the next successive days, either on second, third, or fourth post-operative day. So if you feel that the brain is bulging above the level of inner table of skull, or if you feel from your clinical experience, from the radiological findings, that there is a chance of the brain getting swollen. But in my experience, a patient who qualifies for surgical intervention for subdural hematoma either has significant edema once I evacuate the subdural hematoma, or has radiological factors which predict future appearance of edema in next 2 or 3 days. So I prefer to do an expansile duroplasty. For this one, either I use pericranium or a layer of gallia or artificial substitutes like G-patch, or some in rare conditions, I use a facial adder to close this. There are also my colleagues who don't do a watertight duroplasty. They just place tack sutures and they put a layer of gel foam over this one. It is our experience in our institute, in our place, that this layer of gel forms a good surface protection layer when you open up the brain again for bone flap replacement. So this is your personal preference. I personally prefer an expansile duroplasty. Before you do an expansile duroplasty, I needn't emphasize the importance of meticulous and perfect hemostasis in the subdural space. You can also use a tack-up suture in the midline. If there is no brain swelling, I replace the bone flap. If there is excessive brain swelling, or if I'm expecting a brain swelling in the future, I will not place it back and I will do it like a decompressive craniectomy. I use a closed suction drain, suture back the temporalis muscle, replace the skin flap back, suture the skin flap in layers. So this is the surgical technique for evacuation of an acute subdural hematoma. Yeah. So we have learned how to operate upon a patient with acute subdural hematoma. This procedure, I needn't emphasize again and again. You should be very adept at performing this procedure. You should be rapid, you should be meticulous. This is a life-saving procedure, and when done properly, and more than done properly, when done in time, when the patient is in a good neurological position. If it is done, then the results are awesome. You can actually save a number of lives by this procedure. Okay, let's end this session now. So in the next session, I'll be coming back with another emergency neurosurgical procedure. If anyone wants to speak to me, want my appointment, can WhatsApp me on the number given below. And if any patient have any doubt, wants to contact me for whatever reasons may it be, they can contact me on the same WhatsApp number. Remember to subscribe to my channel. Thank you.